Thank you. All right, and we are focusing this on the physician reporting, and I wanted to let you know that the information was current at the time it was published, but I do want to let you know that there is already one CPT errata sheet that's been published, and we're expecting more just because of some of the information that came out during the CPT symposium. So kind of a high-level overview, we'll take a look at the code changes, take a look at some of the significant changes to the work RVUs, and there are some significant changes to coding guidelines, and kind of review some of the rationale relating to the code changes. And so just kind of our high-level overview, in our totals, we're just including the ones that were added, deleted, or revised for 2022. When the CPT editorial panel sends out their email, they include anything that is new to the book. We're just including the codes that are new for the year because, as you know, with all of the updates, because of the COVID pandemic, there were a lot of mid-month updates, and so we did not include those here because they were already published. So, and we also I didn't include all of the changes to like some of the short and medium descriptions and some of the minor spacing and punctuation changes. I did include a few just so you could see what I mean by a minor change. And overall, it's not that great of a change in the number of codes, which is why I thought, oh, we could do this in an hour, no problem. It's when we get into looking at some of the rationale and some of the guideline changes where you'll also need to go look that kind of threw us for a loop. All right, so with the evaluation and management codes, we're not going to discuss the split visit issue today because that is not something that comes from CPT. We'll discuss it in the physician final rule webinar, which is December 15th. So this minor change, they just removed that. Usually the presenting problems are minimal, just so that it aligns with the rest of the evaluation and the office outpatient E&M codes. All right, so for the revised codes, we've got chronic care management, the assessment and care planning, where really they inserted the word that in between conditions, place, blah, 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 and they've added the word that, and they've changed some of the semicolons to parentheses because they've updated some of the parent-child codes that go along with it. So, and the descriptions for some of these take the whole page, so I didn't want to do that to you. But I did include an example so you can see this. But one of the new updates for the care management services includes that it's establishing, implementing, revising, or monitoring the care plan, that it includes the coordination of care of other professionals and agencies, and educating the patient or caregiver about the patient's condition, care plan, and prognosis. So that doesn't mean you have to change it every time, but if it's, you are monitoring that care plan. So, make sure that you're, reviewing it and making changes as needed. And really what this does is it kind of puts this in alignment with the CMS guidelines. And so we've got 2 G codes for principal care management that are going to be new CPT codes. They're adding add-on codes for those principal care management codes. There's a new add-on code for the chronic care management. And so, as I mentioned, it aligns with the CMS criteria, and also clarifications related to other services, such as, provided with the same month, the time, the communication, and also how it relates to transitional care management have been added. So there are lots of changes to the CPT parentheticals. And so there's slight revisions to other care management codes, including the psychiatric collaborative care management. So be sure to watch parenthetical notes throughout the E&M section for changes as to what can be reported during the same month as the other codes. The main point being only count each minute once. So if you are providing care management codes or psychiatric collaborative care management codes, that can only be provided, you know, if you're providing that psychiatric collaborative care management and reporting that, you count that time for only that service. And so what they have done now is they have created a kind of a hierarchy of codes so that you have your codes with your, for your physician or your qualified healthcare professional, which is your nurse practitioners, physician assistants, with separate codes for clinical staff. And then each one will have for a first 30 minutes and then each additional 30 minutes. And so this is one of the G codes that's being deleted. As I said, you can see that this takes up the entire page. It's like a wall of documentation here. And it can be very overwhelming. So here's one of the new codes. And so I highlighted the word that because that's one of the changes that's in the revisions. And so what they've done is for the care management codes, the descriptions now kind of follow this hierarchy. So your principal care management services are for a single high-risk disease that have the following required elements. You know, that it is expected to last at least 3 months and that places the patient at significant risk of the hospitalization, exacerbation, and that you're going to have the development, monitoring, or revision of a disease-specific care plan. And, you know, that there are going to be frequent adjustments to the medication regimen and ongoing care and communication. And this particular code is for that first 30 minutes provided by the physician or your non-physician practitioner. So the intent for this service is that it's not supposed to be reported for a prolonged number of months for the same patient. And it was really designed with pediatric primary care in mind. But if it fits for a specialist, they are doing all of these, then the specialist can report this if no other physician or non-physician practitioner is reporting the care management and the chronic care management services. So just kind of keep that in mind. So, and so then here, of course, is that each additional 30 minutes for the physician or qualified healthcare professional. And then here you've got the code for the first 30 minutes of clinical staff time that as they're directed by the physician or QHP, and then each additional 30 minutes of time. So you've got that kind of hierarchy going for some of these codes, and that's what a lot of the revisions are going to include. Now, what I've done here is I've included kind of a chart on how, for the minutes of reporting in CPT for this year, the manual, they have included more charts to help you with reporting minutes. And they've also added a lot more illustrations. So especially for the disc arthrodesis or the foraminectomy stuff. So it's a lot more helpful. All right, so here we've got your chronic care management. So this one is a new add-on code, and it is to go with that already established chronic care management code, the 99490, so that the physicians actually have a way to report the additional time. So not a huge change in the code, just allowing for, again, and I meant it should be reported with the 99491, my apologies. So you've got your 99490 for your clinical staff, 99439 for the add-on for each additional minute. And so then your physicians and codes following. All right, and then we've got the complex care management services. So these are for your clinical staff, and these are the unit max per month. All right, and then for the principal care management, again, we've gone over these new codes, and just so you're aware that you have to hit that, to get that add-on code for the 99425, you have to hit that 60 minutes. So they're getting more graphic in those. So sometimes it fuzzes it a little bit about, okay, when I'm hitting midpoint, that can cause some problems. And so what I wanted to do here is show you some of the other care management services. There are some remote physiological monitoring. We'll get into some of these when we get down into the medicine section. And so these are services that cannot be reported together. So just be sure that you're taking a look at these. But also what was pointed out during the CPT symposium and says that there will be some, they think something is an error, is that the 99605 through the 99607, the medication treatment codes, they think that might be an error because they're not based on time. And so that's also with the team conference without the patient. There's no time in that, so there's no way to count the time twice. And then also the 99474, that was actually left off the list. And so that's why I said, be sure to watch for the errata updates. All right, and so just making sure that, for those services, any code, make sure you're not counting the same time twice. And then also your education training for self-management, any telephone services or digital services, just make sure that you're not reporting those and double dipping. All right. And some more of the other exclusions. All right, so CMS on transitional care management, of course, differs from what CPT said. So the care management should not be reported by the same practitioner for services furnished during the 30-day transitional care management service period, but CPT allows it as long as you're not counting that time twice. So for transitional care management and your CCM, just make sure that you're following the payer guidelines on what they follow, whether it's the CMS guidelines or if they allow CPT guidelines. All right, and so here we've got the work RVUs for you. And then there is a revised guideline for the 90785, and even though this is in the psychiatric system, it's really revised regarding the evaluation and management system that it was being reported along with. And the 90785 is your psychiatric interactive complexity guideline charge, and it requires a psychiatric diagnostic evaluation or a psychotherapy service. And that's whether or not the evaluation and management is reported. And so I'll show you the guideline here in a little bit, but it removes the allowance for any language translation because that is part of it's actually part of the civil rights stuff that added Medicare in the first place, that you need to allow for people that speak different languages, and that is not supposed to be considered an interactive complexity issue. And then it also removes some of the description of a typical patient. And so the psychiatric, the 90785, with the interactive complexity, it's the need to manage the maladaptive communications, the caregiver emotions or behavior that interferes with the caregiver's understanding, And then the evidence or disclosure of a sentinel event reported to a third party. And so this one is really the one that has the updates. So the use of play equipment or other devices. This is where they've removed the interpreter or translator to communicate with the patient. And then the patient has not developed or has lost either the expressive language communication skills to explain their stuff. So it's just a little bit of an update there. All right, so let's get into some of the anesthesia changes. There are just a few. CPT codes 01935 and 36 are being deleted. The new codes were created by the anatomical location of the spine, and it's to help coincide with the other CPT codes that are related to the spine. So there's like one for the cervical thoracic, and then the second one is for lumbar or sacral. And then when they were doing the review, the CPT review committee found there was really no need to distinguish whether it was diagnostic or therapeutic. So the codes can be updated. And then there's been a parenthetical note update for the existing code, the 00600, just to point coders to the brand new codes. And here we've got them. So the first two are for an injection and drainage or aspiration procedure. Again, the first one's for cervical or thoracic, second one's for lumbar or sacral. The 1939 and the 1940 are for the destruction procedures by your neurolytic agent, and then your 1941 and 1942 are for your intravertebral procedures like your kyphoplasty or your vertebroplasty. And this is for percutaneous image guidance and not for the open image guidance. All right, so let's get into the surgery section here. In the Integumentary system, there's only one update, and that's a revised code. So for your insertion for the drug delivery implant, they're kind of removing the non-biodegradable, but adding it back. They're also including that it can be for anything that is bioresorbable, biodegradable, or non-biodegradable. There is no procedure for the removal, so they just say to use an unlisted code. Because really only the non-biodegradable would need to have a removal because the other one went out. Now, where they have some big guideline changes is in the fracture care. And there were only a couple of updates to the codes, but for the guideline changes, you'll want to take a look at those because the guidelines now say that all services in the musculoskeletal system section include the application and removal of the first cast, the splint, or the traction device. And that if the cast is removed by somebody other than the provider who put the cast on, then you can report the cast removal code. And then any subsequent replacement during or after the global period may be reported separately. And then because the splinting or strapping is not considered part of the preoperative care, modifier 56 is not necessarily needed. But, you know, payers make their own rules on some of the modifiers, so be sure to follow those. Now, they've added some descriptions or updated descriptions in or definitions in the guidelines. So the manipulation, and so that's the reduction of a fracture by the application of manually applied forces or traction to achieve the alignment of the fracture or a dislocation. And so that would be something like if you're watching the Lethal Weapon series where, you know, the guy whacking his shoulder into the wall to put it back into place, that's manually applied force. All right, so traction is considered the application of a distraction or traction force to the spine or lib. And so the skeletal traction is going to include a wire or a pin or something that penetrates the bone. And then skin traction is really the application of the force using a strapping or a device that's applied directly to the skin only. And so closed treatment means that the treatment site is not surgically open. And so it's not exposed to the external environment. And so but closed treatment can be performed without manipulation or with manipulation or with traction or with skin traction. So just because it's manipulated does not mean it can't be closed treatment. And so one piece that they did add that's kind of important is that casting, splinting, or strapping used solely to temporarily stabilize the fracture for a patient comfort is not considered closed treatment. So we'll come into a part of that. And then we've got percutaneous skeletal fixation. So it's not, so it's neither open or closed. It's kind of in the in-between. So fracture fragments are not visualized, but the fixation is placed across the fracture site. And that's usually using imaging guidance. And then the open treatment, that's where you are, you know, cutting in and going in there and looking around. Okay, so we've got the external fixation. So they've defined the, you know, the uniplanar versus multiplanar fixation and how extensive those can be. All right, so, and then one thing, when you're reporting the fracture or dislocation treatment codes, so the physician or the other qualified healthcare professional, providing the fracture or dislocation treatment should report the appropriate fracture dislocation treatment codes for the service that is being provided. So if the person providing the initial treatment will not be providing subsequent treatment, you should append modifier 54 to the codes. So, and if treatment of a fracture as defined above is not performed, you can report that with an evaluation and management code. And so those are in the guidelines. You can go read those at your leisure. But let's say you have a patient who goes to the emergency department with a non-displaced radial distal radius fracture. And the physician decides, well, the fracture doesn't need reduction, and puts the patient in a short arm cast or a splint. And the emergency department provider will not be providing the follow-up care. How do you report that? Well, you got a couple of different ways to go there. So you can either report like your new patient evaluation and management and a CAST application, or a 90-day global code for the closed treatment without manipulation, and then modifier 54. So you would either report the E&M code with the CAST application or the fracture code, but you wouldn't report secondly. So in the instance where the ED provider says, okay, I'm going to report this with an E&M visit and the CAST application, and then send you over to go see the orthopedist, then that orthopedist office would then report the follow-up care with either like your E&M codes and the CAST application visits at, as needed, or you could kind of duke it out how you're going to do the reporting of the fracture care. So it can get a little muddy in those. areas. So you might want to make sure that you sit down and decide how are you going to treat those types of patients. So just, so then, and then also the example given is, let's say, okay, well, let's say after they've done the cast application and before they get to the orthopedist office, then there's some type of displacement, then the orthopedist office does perform that reduction, like the code 25605, then that procedure can be reported because it's distinct and different. So I think what they tried to do was kind of try to clarify things, but it kind of muddied it a little bit. So just be careful that you kind of have that dual option for fracture care. So you can either report the E&M code or the ED visit with the cast application, or you can assume care for the fracture placement, fracture care, which has that, of course, 90-day global, and then also provide the follow-up treatment. So it could be that sometimes it works out better one way than the other, but just to, you might want to go through and read those guidelines just to see what would be, what's going to apply in your scenario. All right, so they did delete code 21310, which is your closed treatment of your nasal bone fracture, and just said, when you do that, use an appropriate evaluation and management code. And so then they've updated the other closed treatment of the nasal bone fractures to include that it has to be with manipulation. And so then they're distinguished by whether it's without stabilization. And so that means that they would do some type of manipulation or reduction, usually without an incision. But then there's also no casting or strapping or anything to reinforce the fracture. And then the closed treatment with manipulation and with stabilization, usually that's going to be done in the operating room, but it doesn't mean that it has to be. And then there has to have some type of stabilizing dressing, and that could be, the steri strips, the thermoplast, some type of molding to help that cast, to help with that stabilization. All right, so the musculoskeletal system, it's just, these are mainly for, just kind of streamlining the conventions. And so what they're doing is they're saying the arthrodesis, the single inner space below the C2 segment. So, and that's going to, so instead of being a single level, they're calling it an inner space because it's, kind of between the two discs there. And so that change affects 22600 through the 22614. And you'll see that in some of the other codes that it'll start mentioning inner space. So the 22633 and 34, they've removed the inner space and segment just to say inner space. And so they've added some new definitions. They've also added some pictures to go along with this. So just saying, a corpectomy is the removal of a vertebral body during spinal surgery. And then some of these also show how much the percentage has to be taken for it to be considered the procedure. So we've got a facetotomy, and then the foraminotomy. And so the intravertebral foramen is bordered by the superior notch of the adjacent vertebra, the inferior notch of the vertebra, the facet joint, and the intervertebral disc. So it just kind of gives you some more information. Also the hemilaminectomy, the lamina. And so these, these definitions are to be used with the arthrodesis decompression codes. And so I would urge you, if you work in this part of the anatomy, to see the visual definitions of the spinal anatomy and procedures that they've got in the book, because it's very helpful. And then for the valuations of these were considered misvalued. And so it looks like you kind of took a hit here on the work RVUs. All right, so these are some deleted codes. The valvotomy and the closure of the aortico left ventricular tunnel. The rationale was it's because these are not really done because of changes in medical developments and technology. There are other procedure codes that are used. And so if you are providing for this, you are providing this system, this procedure, to go ahead and use that unlisted code to report. But a lot of times they'll, when they're doing their review, if it's under a specific number of claims that come in for that, they decide, well, it's not being reported very often, and they delete the codes. All right. Oops. Oh, I thought I missed a slide. Okay. So here we've got your valvotomy, kind of a change to the punctuation, nothing big. But the 35600 is now becoming a parent code and is no longer listed separately in addition to. It is its own specific procedure, and that's because of some of the code changes that are coming up. And so this one is for the open harvest, and one of the new codes that we have later is for the percutaneous harvest. So there will be different codes. All right. And so for anybody that does the exclusion of a left atrial appendage, LAA, there are new codes to be able to report that procedure. And so it is the top two codes are open, and the bottom one is for your thoracoscopic. And then your 33268 also is a list separately in addition to the code for the primary procedure. And so the 33267 is only reported when there is no concurrently performed procedure requiring the sternotomy or a thoracotomy approach. And so the 33268 then is to be reported as the list when you have that other sternotomy or thoracotomy approach. And of course, they're going to be, the RVUs will be different because of the amount of work that goes into those. And then just kind of a caution, the 33269 can be reported for the for the exclusion, unless you're doing a maze or mitral valve procedure during the same operative session. So here's a picture of a clip going in there and cutting those out. So here you can see the valuations, the RVUs, the 33267, because it's done without another procedure that has that sternotomy or thoracotomy, is valued way higher than that add-on code for the 33268. All right, and so here we've got another new code, the 33370, which is a transcatheter placement and subsequent removal of a cerebral embolic protection device or devices. And so that is going to include the arterial access, the catheterization, any imaging, and any radiological supervision or interpretation. And that is it's listed in addition to the code for your primary procedures, because it's usually done in addition to your transcatheter aortic valve replacement, your TAVR or your TAVI procedures. And the catheter is designed to capture any embolic material that might be loosened when you're doing the TAVR or the TAVI procedure. And so it captures anything that kind of breaks away and floats loose, so that it will help prevent any potential cerebrovascular accidents. And so it includes any additional or multiple filters, so they're not separately reportable. And so the code, it includes the removal of the filters and any of the debris, the removal of the arterial sheath, and of course the closure of the arteriotomy to get access for that sheath in there. And so here we've got the endoscopy, the endoscopic harvest of that upper extremity. And so here we've got the work RVUs for those codes. All right, so there is a whole new subsection of endovascular repair of congenital heart and vascular defects. And there are new guidelines. So there are 10 of green pages in your CPT book along with this one. And so we're starting out with the coarctation of the aorta. And some of the changes here also affect some of the reporting in the medicine section. So make sure you look. And so it depends on where the squeeze is, whether in relation to the ductus arteriosus. So it's either before or after. And we've got a picture there for your postductal and your preductal. And so the codes, it's an endovascular stent repair of coarctation of the ascending transverse or descending thoracic or abdominal aorta, and it involves stent placement, and it's either across major side branches or not crossing major side branches. And then the 33897 is if you're doing something, the angioplasty without the use of a stent. All right, so what are those major side branches? So I've got them listed out here for you. For the thoracic, that's your brachiocephalic, carotid, subclavian, your major side branches of your abdominal or your celiac, and inferior mesenteric, and your renal arteries. So code selection is determined on, are you crossing the major branches or not? And so those codes, they include the stent introduction, any manipulation, positioning or deployment, temporary pacemaker insertion for rapid pacing to help facilitate that stent positioning, if that is performed, as well as any additional stent delivery that goes along with that initial stent for extension purposes. And so if you're also doing your diagnostic right heart cath at the same setting, then you can go ahead and report those separately. And then also any other interventional procedures that are performed at the same time can be reported separately if performed before or after the stent deployment. So as long as it's not to help facilitate that stent deployment for the coarctation, it will be separately reportable. And so here are the work RVUs that have been established for those new procedure codes. All right, and going down the system here, we've got some digestive system. The 43850 and 55 have both been deleted. It's basically, these are really not being done any longer because the technology in medicine has changed, so they're not doing these. And so there were no suggested replacements made by CPT. And so then general guidance would be, if you're doing these, you can use an unlisted code. So one of the new codes, this one is really cool, the 42975, it's a drug-induced sleep endoscopy with dynamic evaluation of the velum, pharynx, tongue base, and larynx for the evaluation of sleep disordered breathing, flexible and diagnostic. So the documentation should include each of those sites mentioned, the velum, the pharynx, tongue base. And so it's supposed to be dynamic, meaning moving. And so even though the patient's asleep, while they're breathing, the physician may, move their head side to side, tilt it, just to see how is the structure of the air passage behaving and or not behaving, or is it the tongue, the glottis, so that they are evaluating for what type of obstructive sleep apnea surgery might the patient need. So it's not like the other medicine code that's the swallow function. It's very different. So currently CPT said they were seeing this reported with things like a laryngoscopy, a bronchoscopy, the 92502, your otolaryngolic examination, but really those codes alone or in combination really don't capture the work that's involved with that. So they've created the new code to report it. And so another new code in this one is what they call the POEM, or the peroral endoscopic myotomy. And this is usually performed for achalasia. There are other CPT codes that kind of describe an esophagomyotomy, but they have different approaches. And so this one is for the lower esophageal approach, or transoral approach. Sorry about that. And so here's just kind of a picture describing that. And then here are the work RVUs for those new codes. Okay, so heading into the male genital system revised codes. This one is really kind of a change of terminology. It's because it's really a revision of a prior hypospadias repair. And so they wanted to make sure that they were removing the word cripple from the description, because that can kind of be seen as offensive, especially if somebody is looking at the description of the CPT code and don't realize that it just means, you know, that it's not working as functioned. So this will repair that oversight. Okay, and then some new codes here. You have your transurethral transperineal adjustable balloon continence device. Most of the time you will see the bilateral insertion, and these of course are going to include your cystourethropy and your imaging guidance. And then they have also included one for a unilateral insertion. And the unilateral insertion is usually going to be like a second service, because the bilateral insertion would have been done previously, but you know, maybe the device has failed or it's migrated, and so you have to go in but you only needed to do it on one side. You have that that one side that you can go in and do the change on. And then you don't have to worry about modifiers. Yay. Okay, and so also with those, they also have the removal code if you're taking them out. So if you have the failed device, you can go in and remove it. And then you have the unilaterally that you can use for the replacement. And that one is for each balloon. So it could be if both balloons fail, you know, you could go in, take both of them out and do another bilateral. So whatever is going to be necessary to report your procedure. And then you have the adjustment of the fluid volume of the balloon, and that is done once per encounter. So it even if you only do one side or if you do both sides, it doesn't matter. You just report it once per encounter. And they replace the category 3 codes of the 0548T and 0551T. And of course, they really stress that these include the cystourethropy and the imaging guidance. All right, and then for the female genital system, there's one code that was replaced, the surgical treatment of an ectopic pregnancy requiring a total hysterectomy. And there was really no suggested replacement code. So it could be that, you know, you could use an unlisted code or just maybe one of the total hysterectomy codes. All right. And so into the nervous system we go. And these codes are being deleted, but don't worry. There are some new codes, but they didn't necessarily crosswalk one-to-one, so there really were no suggested replacements. One of the revised codes is that instead of saying incision for, kind of the standard now is to say the open implantation, just so that you know that it is an open procedure versus percutaneous, because sometimes for percutaneous, you can make a little incision. And then this change also affects code 64575, 64580, and 81. All right. Now, these are for the laser interstitial thermal therapy of a lesion. And the differentiator here is that the 61736 is for that single trajectory for one simple lesion. And then the 61737 is for multiple trajectories, or for multiple or complex lesions. So that complex lesion could still be one lesion, but you might have to take multiple trajectories to get there. So let me kind of show you a picture here. And so it does include the creation of burr holes. And so in this picture, this is showing one single trajectory on one lesion. So if you have to do multiple trajectories to target that lesion, you might need to use the multiple or complex. There was really not a lot of guidance given on how you would do that, but I'm assuming if you do these, when it's multiple or complex, you're going to know. Because it involves the stereotactic placement of a laser fiber into an intracranial target lesion. And so there is thermal and MRI image monitoring. And so it, do not report with a twist drill craniectomy or burr hole craniectomy. That's included. And that also includes the transfer patient to an MRI suite for the volumetric images, all while maintaining that sterile environment. And multiple, really, it just means multiple trajectories or multiple lesions. So it might be, if I back up here, if I had to have a second trajectory come in, maybe from the right-hand side to target another part of that lesion, that would be multiple. All right, and so here we've got the work RVUs for that. Okay, so we do have some new laminotomy codes. So this is, remember the different definitions we went through for the laminectomy, facetectomy, or foraminotomy. Oh, word salad. So this can be unilateral or bilateral with the decompression of the spinal cord. I mean, they really can spell it out when they're doing this. And so if you would notice, though, the descriptions do state that this is during a posterior interbody arthrodesis. The 5.2 is on the lumbar single vertebral segment, and then the 5.3 is for the lumbar and each additional segment. And those are used in conjunction usually with the 22630 through 22634, the arthrodesis codes. And so this allows for the separate reporting of the decompression from the fusion. And you have to make sure that that decompression, if it's solely to prepare the inner space for fusion, it's not separately reported. And then we've got the work RVUs here. All right, and so here we have the 64582, which is an open implantation of a hypoglossal nerve neurostimulator array. for the pulse generator. And we have several codes of these. And so the 8.3 is your revision or replacement of the respiratory sensor electrode or electrode array. And then we've got 8.4, which is the removal of the of that generator. And so this is, of course, to treat obstructive sleep apnea. And they were created to identify the open implantation for a hypoglossal nerve stimulator systems. These are supposed to replace category 3 codes, the 0466T through 0468T, but they are a little bit more robust, and they include the sensor and the stimulation components. And the hypoglossal nerve, it's considered a cranial nerve, but the work to do this is much more extensive because you have to be careful of while you're going through there and exposing the nerve to go in there. And so these codes capture the extra work performed when placing that inspiratory sensor. And so the new codes also represent the total effort that's necessary. And so on this page here, you can see where the upper portion of the picture is where you've gone in and gone through to the place part of that, and then after you've placed the sensors, and then of course your work RVU. Okay, and so we've got a thermal destruction of an intraosseous basovertebral nerve. It's including all imaging and guidance. The 64628 is for the first 2 vertebral bodies, lumbar or sacral. And then after that, this 64629 is for each additional one there. And so the 64628 is used to report the destruction of that nerve. 64629 is each additional body. And previously there were no codes that existed to report the procedure. And it might help to provide effective relief for patients suffering from certain types of chronic low back pain. And it does include the imaging guidance, so it is not reported with the 77003 or the 77012. And here are the work RVUs for those. And then there were some revalued codes, the destruction by neurolytic agent. And so if you do a lot of the 64633, the work RVU has gone down by about 0.50. And then the 64635 is also, it's gone down about 46.46 points there too. All right, and there have been quite a few changes in the eye and the ocular adnexa area. And so for the, these two are being revised. It was for it was for 1 or more sessions. And so these have been revalued as well as when they were, because when they were going through and taking a look to see how many times were people coming in for repeat sessions, that's kind of what drove this process. And they were, the codes were reviewed due to increased utilization. And so they have now been revised to be consistent with other laser photocoagulation codes. And so they removed that 1 or more sessions. So now you can, it's been valued as 1 session, so you can report it each time that the patient comes in and you perform that service. So while it looks like you may have taken a hit because the work RVUs are so much lower, you might actually gain because you're now able to report, you know, however many times that patient comes in. Because if you actually see this patient and do this procedure on the patient, you know, 3 to 4 times, you're already ahead. All right, and so another CPT code that takes takes up the entire page here. So here we've got a cataract removal, and it's also you have the insertion of an intraocular, and that is meaning like a trabecular meshwork. It could be supraciliary, subchoroidal. In the anterior segment, it's an anterior segment aqueous drainage device, and it can be, and it's without an extraocular reservoir, internal approach, and one or more. And there's other codes that go along with this too. And so here we've got an extracapsular cataract removal with the insertion of your lens, and also the insertion of your intraocular trabecular meshwork as well. And then another new code is 68841, the insertion of a drug-eluting implant that includes the punctal dilation when performed, and it's specific to the lacrimal caniculus, each one. And so for this code, they're anticipating that multiple applications can be used. Some of the, if it could be, for steroid use after surgery, dry eye, glaucoma, and some of the implants will need to be removed while others are just going to disintegrate or fall out. And it may be reported for each eye, and it's specific to the caniculus. Because there's another one that further on down the duct there. And so here is the work RVU associated with those. And then we also have some revalued codes. And part of the 66174 is the transluminal dilation of the aqueous outflow canal without the retention of the device or stent. The 66175 is with the retention of a device or stent. And the reason for part of that is that this 65820, which is your goniotomy, is considered inherent to the 66174, but not the 66175. So they are adding new parenthetical notes to help you with the reporting of those. And then here are some revalued codes for your strabismus surgery. So really the only one that's going up is the 67318. And some more revalued codes. Okay, and then for the auditory system, take a deep breath and get ready for the next session. All right, so do we have your 69715 has been deleted, and your 69718 has been deleted. These codes are going to require 2 codes for the replacement. And so what they've really done is kind of rewired these codes so that it's just for the implant procedure. And then if you're doing any mastoidectomy procedure, that is reported separately. So of course that is going to change the valuation. So for the 69714 and the 69717, these are for your osseointegrated implant. And so they're, instead of just saying temporal bone, they're just saying for the skull. And for these are ones that have the percutaneous attachment for the external speech processor. And sometimes there have been infections that kind of go along with that attachment, that external attachment. And so that's kind of part of what stimulated part of this review. And so the next 2 codes, we have the 69716 and the 69719 for those magnetic transcutaneous attachments. So the the external speech processor is attached by a magnet to the skull rather than having the, like the screw protrude out for it to attach to. And so then it depends on which procedure you're doing as to whether or not that mastoidectomy needs to be done. And so then some other new codes are for your, the removal of, and the 69726 is for the one with the percutaneous attachment to that external speech processor. And then the 69729 is for the magnetic attachment to the speech processor. And so some of the new guidelines are that stating now that if you have any other repairs made to the middle ear or to your mastoid or the mastoid procedures, those can be reported separately when they're performed, because they can be performed for different indications. And so they want to kind of give you the ability to kind of grab the services to report what the patient is having done. Okay, so the 69716 and 19 are the child codes, and then we've got the removal of the implants, and then so the revaluation, and you'll see on the 69714 and the 69717 that those have really been reduced, but you're now able to report the mastoid procedure separate, so it may not be a total loss there. All right. And I thought this cartoon was funny because it's the MRI Carrie will be singing her latest hits during the scan. And so there are some deleted codes. So the 72275 epidurography, really those are being done along with the spinal procedures. And they're finding that radiology is no longer the dominant reporting provider. So really, the person performing the surgical procedure is doing the radiological procedure. So there's really no longer a need for the code. And then there's 76101 and 02 were deleted because they just were not really being reported at all. Okay, so this one kind of seems weird that, I'm pointing this one out because it's really just spelling out left ventricular, right ventricular, and that's just because they're moving that to their naming conventions. But what's important is that they are changing venous to vascular. And so that is really helping to provide clarity that the examination includes the vascular evaluation of the vessels around the heart when that's performed. And the code 75573 is specific for use in patients with congenital heart disease. And so, but the 75574 is still the correct code to use when the coronary arteries and bypass grafts are being studied. And so really left ventricular and right ventricular, that's really just meeting their spelling conventions. All right, and here we've got some codes for trabecular bone score studies. And so what this is doing is it is taking already performed exams, and this could be your DEXA scan or maybe even any other imaging data that's on a grayscale variogram, and is using additional computer programs to evaluate for the bone microarchitecture and how stable that is. And so this one, the 77089, is the like kind of the calculation with your interpretation and report on a fracture risk. The 77090 is the technical preparation, and the transmission of the data for analysis to be performed. The 77091 is the technical calculation only. And the 77092 is for the interpretation and report only. So what it does is it actually allows for all kinds of types of reporting. The 77089 is the entire global service. So if you do all of it, you can report that. But if you're going to parse it out, the 77090 is for the transmission for offsite analysis. And then the 77091 is the technical component for the offsite person doing that analysis. And then the 77092 would be for the professional component for the interpretation and report. So that allows you to report the codes in a manner that you see fit. And what this is, it's a measurement of the structural condition of the bone, a microarchitecture, and it's different from a DEXA scan. Again, it can be used either on data from a DEXA or a digital X-ray. And someone that has a high TBS score just means that the microarchitecture is dense and well connected with little spaces between the trabecula. And then the low score means it's incomplete and it's poorly connected and there's wide spaces between the trabecula. And that might help predict the risk of a major osteoporotic fracture. And anyway, so here we've got the work RVUs, and you'll notice the 77090 and 91 were technical components only, so there's no physician work involved on those. All right, and boy, didn't Path and Lab give us a run for the money this past year. But a lot of the changes were performed in 2020 and 2021, so they weren't reported in the code book, so we won't be going over all of those. But there are some major changes for the 80500 and the 80502, which is your pathology consultations. There are some suggested replacements, and we'll be going over those codes in a minute. And then the 0208U was deleted, and there's no suggested replacement. And it could be that the manufacturer just isn't providing support for that test anymore, that it's not being manufactured anymore. All right, and so there were a couple of updates just to kind of go over where they've updated this a little bit. The 81228, they are taking out some of the bacterial, artificial chromosome or oligo-based hybridization on those. And a lot of the evaluation for the pathology services is as they see the need for additional tests and CPT codes to be used for tracking purposes, they'll be created. And so that's why there can be such a large update in some of these. So this one is updating so that you're looking for your comparative genomic hybridization microarray analysis rather than just for chromosomal abnormalities. And then again, just a slight change here, but they are adding a new code into the parenthetical notes. And all right, so there are lots and lots of lab codes. I'm not going to go over all of these, but I do have the new codes here available so you can take a look. There is a new code for checking for the hydroxychloroquine. And so here we've also got the genome-wide analysis that was added to the parenthetical note for the one that I just showed you, because it, I guess, kind of grew up and got its own code. And so here we've got the Anti-neutrophil cytoplasmic antibodies. I don't like to flip through these too fast because I get motion sickness when I do that. This 87154 there on the bottom is for culture typing. And then some new oncology codes. And so this is kind of interesting where you get into a lab test to check the neurology for Alzheimer's disease, which I think is kind of fascinating. They also have some that are now for psychiatry where they can look for mood disorders in the RNA or stress disorders. To me, that's just kind of fascinating. And then here you've got some additional oncology ones, breast ductal carcinoma in situ, and so forth. More. We've got some hematology codes there. And so for the new pathology codes, there are, you'll notice that these look and feel more like the CPT office evaluation and management codes. And it is kind of streamlining with those. So here you've got your 80503, which is for your clinical consultation for a clinical problem with a limited review, a straightforward medical decision-making, 5 to 20 minutes total time. 80504 is your moderately complex problem with a moderate level. And then your 80805, which is your high level. And then your 80506 is your prolonged service. And so just to kind of point out, they did update the guidelines. And so it's the physician review of the pathology and laboratory findings when provided in the course of care to provide it to patients. And so kind of this is also non-face-to-face time activities can be associated with the E&M service. And then also communicating that to the patient or caregiver, and that might be part of the service as well. And just remember there needs to be a request for the consultation or the clinical assessment, and then a written report is necessary. Code selection is based on time or level of medical decision-making. And then also the report might be necessary due to state regulations. For example, when pathology, when a specimen is sent over after surgery. And so that could be one reason why it's being requested. So the state regulation is a request. And so it is very similar to the E&M office visit changes. And just as a heads up, there aren't any big changes for E&M in 2022. But there are slated to be some for 2023. So I would suggest going out to the AMA's website and looking for the upcoming trainings because they had a whole bunch of free trainings prior to the changes that came up for 2021. And they're expecting to do more of the same for those. And so here we've got the work RVUs for those path and lab codes. Unfortunately, CMS has not yet published the lab fee schedule. It usually can sometimes, well, we've even had a couple of times where it hasn't been published until the first week of January. And so I just check for it every day and pray it comes in before then. All right, medicine. Oh, goodness. These codes have been deleted. Suggested replacements are the unlisted codes, but there are some new auditory evoked potential testing codes that might be used instead. And these were really deleted because the clinical practice has changed over time, and these codes were really obsolete. Some more, of course, they are the heart catheterization ones are being deleted. We'll go over those in a second. I've listed some of the suggested replacements. And I've also got some other charts in here to kind of help you with some of the changes. All right, and so the orthoptic training, it's just they revised the verbiage here. Now, your 93653 is being kind of redone. And so just make sure that you realize that the 3D mapping and your left atrial pacing are now bundled into the service when it's done. So it's kind of expanding the capacity of this service, and also the same with the 93654. And so, of course, this one, the 3D mapping and your intracardiac echocardiography are now bundled. And there is a new table in the CPT book to help you with code selection. So you might want to take a look at that. It's very helpful. So kind of switch into new codes. We've got the hepatitis B vaccine. This is still waiting for FDA approval. We have your gastrointestinal tract imaging intraluminal. So this would be if you're using a capsule endoscopy, and it's for the coding. All right. So I had mentioned that there were some new codes for auditory evoked potentials. So you'll also want to make sure you check codes, the 926, 26, and 27, the evaluation of auditory function tests, because there are some changes there. And so with the addition of these, some folks have asked whether the 92653 should be reported in conjunction with the 92651 and 52, because these codes report the evaluation of waveform latency and neural integrity. And so just to take a look at this, your auditory evoked potentials is, the response is evaluated using a moderate to high level stimulus, which is part of the procedure described by the 3 codes. So do not report the 92651 and 52 in conjunction with 92653, because that's part of it. All right, and here are the work RVUs for the new codes. And so here we get into the 3D echocardiographic imaging and post-processing. And so this just adds kind of another dimension of or depth to what the person can see during the test. And when you're doing the transthoracic echocardiogram, the TTE, it's only if it's congenital only, and but the transesophageal echocardiogram, or your TEE, can be congenital or non-congenital. And then do not use this with other 3D codes. And I've listed those here for you. All right, now, one thing we're going to have to talk about is a new concept before we get into the congenital heart catheterization, because what they talk about is something called a normal native connection, which is where the blood flows along the expected course through the right and left heart chambers and the great vessels. And then there's an abnormal native connection. And then that means the body has kind of formed its own alternative connection for the pathway of the blood flow through that heart and great vessels. And so this is going to be found in patients with abnormal cardiac anatomy. Usually it's going to be your newborns and your pediatrics. And these guys can have a tetralogy of Fallot or a hypoplastic left or right heart. But what they said during the CPT symposium is basically the chamber that is pumping blood is the right heart. And so then how are the blood vessels connecting? Is it then connecting as you would expect, or and following that regular path through the vessels and chambers, or is it or not? And that's how you're going to determine that. So there are pages and subsection guidelines and updates throughout the book. And here's one of the first kind of one of the first graphs, and just be sure that you go through and read, because there's like 2 pages of notes at least. So the normal native connection, the path is flowing through the right and left heart chambers and the great vessels as expected. And so that might be somebody that's got an isolated atrial septal defect or like a ventricular septal defect. But if it's an abnormal connection and and it's connected to the wrong, it's kind of connected backwards, then you would report that with your abnormal native connection codes. And that can be your cyanotic congenital heart defects, any variation of a single ventricle anatomy, unbalanced atrioventricular canal. And so you can see these and take a look at them when you get the slides. And so here are the 2 main right heart cath codes. 93593 is your normal native connections. 93594 is your abnormal. And so, but when you get to like your 93595, which is your left heart cath, it's for normal or abnormal native connections. So just, so kind of watch there. That's kind of why I highlighted this in yellow. We've got your 93596, which is your right and left heart cath for your congenital heart defect for the normal native. And then I had to go to the next page for the same thing with your abnormal native connections. And then you have your 93598 for your cardiac output measurements. And that can be your thermodilution or other indicator dilution method. And this is an add-on code. And then another chart that I've got here for you is kind of crosswalking the procedure, the 2021 codes with the 2022 codes, and kind of get your, gives you an idea of what's included. So their right heart cath, that's, your catheter placement, including your imaging guidance, your blood samples, like things like your fit cardiac output measurements and those types of things. So you've got this chart here. And so go through and remember, I mentioned that there were updates all over the code book. And so here are the codes. They were not kind enough to provide us with a list of where there are revised parenthetical notes and revised guidelines. And then also they did some revisions to modifier 63. Nothing fancy schmancy, but in the long description, it did include the old heart cath codes. And so now they're just including the new heart cath codes. The work reviews. And then there are some updates to your outpatient pulmonary rehab. These 2 codes are replacing an old G code, one without continuous pulse ox and one with continuous pulse ox. And CMS expects that 100% of the time you're going to be reporting the 94626. They have some digital monitoring services for right now respiratory and musculoskeletal systems only, because they were the only 2 systems that were reporting them. And so it has to be an FDA approved device. It has to be ordered by a physician or qualified healthcare professional. It has to be used the 16 days or longer, so that midpoint, and then do not report it with other physiological monitoring services. So here we've got the 98975. So it's your remote therapeutic monitoring, the initial setup and patient education on the use of equipment. And so here we've got the non-therapeutic monitoring of the respiratory system for each 30 days, or the musculoskeletal system. And of course, if there's a more specific CPT code to be used for that monitoring, please use it instead of these codes. Now, an example of a non-physiologic respiratory monitoring system that I found, and I did not go to look for the device, but just as an example, let's say there's an FDA approved device that can be attached to an asthmatic patient's bronchodilator that is going to check and monitor, how many times a day they use it, Are they using it correctly? Also, like, are they also, and it might also monitor things like air quality, and like pollen counts, smoke counts. We have forest fires here, and it can go out of the world. And so it would be monitoring those non-physiologic functions to be able to use that device. And as I said, I didn't go look for any specific devices, and the CPT would not use any brand names. So as the software as a medical device becomes available, as long as it's met the other conditions, you can report those. And so the 98980 is when you have the monitoring treatment, when you have a interactive communication with the patient or caregiver during the calendar month based on time. And so they have to be on a specific treatment plan, use an FDA approved device, and it can be reported during the same service period as like chronic care, transitional care. Time only counts once, and it may not be reported at the same time you're doing an E&M service or an inpatient service. Here are the work RVUs. Those first three are actually the technical components. And then there are changes to the category 3 codes, and I'm whizzing through these because I know we're coming up on time and I still have a lot of slides to go. They took out higher energy on these because it really didn't make any difference to the service that was being performed. This one, the word unilateral has been added to the description. And so they've added some new codes for vertebral tethering, and these are not to be used in conjunction with some of your other spinal surgeries. And it's usually because it does not involve arthrodesis or fusion of the spine, it's to treat scoliosis. And so it's the addition of some structural components to help straighten the spine as the person grows. Some more trabecular meshwork items, and this is when it's done without the cataract removal at the same time. So it should not be reported with the other codes. And so here we've got some new codes for cryogen cooled monopolar, some radio frequency stuff. And so this is for an inserted, a synchronized diaphragmatic stimulation system. And this is to help with the cardiac, someone that's got severe heart failure and they need some help with their outputs. And so they've got it broken down for the insertion of or replacement of the whole shebang, the leads, the generator, and then it follows the other codes where they also have when you're doing the, like the repositioning, the removal, relocation, and then also your device programming when it's in person. So of course, these are not done at the same time as the time you're adding it, inserting it because it's part of the procedure, but afterwards too. So, and then they have some new codes for treatment of amblyopia using an online digital program. So the patient can log in to do some type of evaluation. And I'm sorry that I ran out of time to do all of these, but what I did want to show you is that they have some new codes for when there's your heart, you have dysynchronous firing of your synapses, and they're wanting to go in and do an evaluation of where would be the best place to insert some of your synchronization devices to get things back into sync. And then some MRI, magnetic resonance analysis of tissue composition, just to make sure that you're getting all of that in there. They have the 0699T, the injection of the posterior chamber of the eye for medication, which the other ones were either trabecular or the anterior chamber. And so here is an online digital cognitive behavioral health code for report and some additional amblyopia. It's tough when they don't put them together, but this is like if you're doing the device setup, supply with the initial setup and technical support and all of that. I wanted to show you that back in the back, the last several slides are crosswalks between the category 3 deleted codes and the suggested replacement codes. And there's about 7 slides of those. So Marie, that is going to take us to the end.
Okay, great. So for Q&A, since we're already over time today, what we'll do is we'll pull these questions and we'll put them into a document with the answers. So just look out for those in the next week or two to be posted on our website. And like I said before the presentation, you should be receiving an email by end of day today with the CEU certificates and a link to the recording and slide deck. If you don't receive those by tomorrow morning, go ahead and just shoot us an email and we can help you out with that. And I'm sure we will see some of you next week. But thank you for joining us today, and we hope everyone has a great day.
All right. Thanks, everyone.
Thank you.